welcome to the Nordics, and more specifically to healthtech Nordic. Now, we all know that the pandemic is awful. However, here are the good news. It's also the perfect storm and the point of no return for healthtech.
So today we're going to talk about how healthtech relieves healthcare during and after COVID-19. And we're going to address this issue in three different areas. First, and in part one, we're going to talk about the needs and how the needs have surfaced, and go a bit deeper into the challenges as they have evolved and some pioneer solutions that are addressing them. In part two, we're going to talk about how local and global trends are influencing this issue.
And stay tuned, because finally we're going to listen to a couple of pioneering healthcare providers talking us through their journey and challenges. Welcome.
Careligo is a medtech company, and we're more or less synonymous with our one product, which is called Optilog. So that is what we do, and it's a home-based tool dedicated to improving self-care in the senior populations, specifically the elderly and chronically ill patients who maybe are not tech savvy and will not have smartphones or internet to the extent that we would like them to do. Sure, times are changing, but at this moment, the vast majority of the 80-year-olds who have these multimorbidities are not going to use those tools. So there's a need to meet these people where they are and to get them involved in their own healthcare, and that is what we strive to do with Optilog. I think there are really two forces at play. Like you said, one, you want to keep these patients away from being exposed to contagion, and also that there's been a shift of focus to other treatments. But I think that the reality of the situation is it's much wider than that. I mean, we're talking right now where you alluded to the heart failure patients not seeking care, but we must also understand that heart failure is kind of the amount of all the insults to the heart over the lifespan of a patient, which means that the patients who are not seeking care for heart failure, sure, they're going to probably deteriorate. But we also have all the patients with arrhythmia, with atrial fibrillation, with chronic kidney disease, with ischemia that goes unnoticed, non-STEMIs, for instance, asymptomatic ischemic episodes in these patients. All of these things, uncontrolled blood pressure, I mean, the list goes on and on. All of these things, a few years down the line, if not treated properly today, will then evolve into heart failure. I mean, it is the only cardiovascular disease still increasing in prevalence with the aging population, and with more and more people not getting sufficient care for these other comorbidities, there is a huge risk, I think, for society that the heart failure prevalence is going to increase even further. So I think that the scope of the problem is at least like that, or possibly even greater still. So of course, what we have seen is, there's certainly been a shift within the healthcare organizations where they are more prone to accept digital solutions, which I think is good. This kind of propels society forward in that direction, which is a good thing. And it has certainly also increased the demand for our services. One region in Sweden immediately canceled everything they did and procured our Optilog just to make sure that you can keep these vulnerable patients out of harm's way. So, I mean, I think that this, when we look back in history a few years down the line, this is going to be one of these key events that triggered societal change in terms of deployment and adoption of digital healthcare. Right. So first of all, what we do that kind of differs from other solutions is that we do not simply send patients a box and hope that they can, connect Bluetooth devices and download apps and manage that way, because that does not work for the patients who are 85 or 90. So we visit each and every patient, and that gets some of the healthcare professionals right now to maybe raise an eyebrow and say, hey, we don't want to, expose these people for contagion. But we have in 3 clinical studies proven to reduce the need of hospital care by 38% and reduce the risk of hospital admissions by 50%. So we got to realize, and we have taken lots of precautions to make sure that we do not distribute or spread contagion. So we have new routines in place for that. And we must also realize that one planned visit to these elderly people with all these precautions taken is a lot better than an unplanned visit where they go to the emergency room being exposed to many, many more people who all are there for a reason, probably some of them going to be contagious. So having control of the situation and is just like that a lot better than the unplanned event. But also the result of our visit to these patients will be a 50% risk reduction of having to go and be exposed to that more severe event later. So once we get through that kind of reasoning, rationale, it becomes pretty clear that yes, this is the good way to go. So that was one of the things that we encountered, and we really just immediately prioritized getting new routines in place for our field staff so they could safe and securely interact with these patients. Because, and going back to your point previously, the idea is not to leave these patients out there and forget about them. They still need support and they still need care. What we need to do is we need to make sure and we shift healthcare from acute and emergency settings to a planned and controlled environment. And that's exactly what we do. So from our perspective, it works pretty well. And like I said, we are not losing interest. We are garnering new interest and have been able to launch Optilog in new regions in light of COVID-19. And we predict that's going to be a change that's going to persist and spread through other regions in Sweden too. Basically, there's a danger with remote monitoring. It's not the fix-all solution, because when you think of it, if you equip patients with, for instance, a blood pressure cuff or a saturation measurement unit or something like that, and you send that data to an already bogged down healthcare organization, if you do nothing else than that, you're basically creating more work. Sure, there are great benefits to it, and we do it too. We want you don't have to travel. It's easier for the sick patients. You don't expose them to contagion. But all in all, what remote monitoring then is, it's basically just a long wire from the blood pressure cuff to the healthcare professional. That's not going to cut it. We have to go beyond remote monitoring and into what we call remote care. And there is also an area where we are the only ones. We close the loop in the patient's home in the sense that we have a patented AI engine in our tool that changes the medication based on sensory input from the patient and changes the medications on a daily basis in a unique way for each patient.
At Kind, our purpose and the mission we're on is to help healthcare providers to get access to cheap, secure, and modern technology that is going to help them to communicate more efficiently with their patients. I would say that it's been a couple of different phases. First of all, I would say that at least in the Nordics, this isn't so much a new trend as actually just accentuating a trend that was already there. So we already had a kind of an ongoing process of starting to introduce digital channels and digital meetings in primary care and in generally speaking in healthcare, not only primary care in the Nordics. And I would say that the COVID-19 crisis kind of accentuated that trend that was already there. In some countries, in Brazil, for example, where we're active, I would say that it more kind of developed a new need that weren't necessarily as strong a trend before the COVID-19 crisis as we see now. But I would say that it's been a couple of different phases. If we look at in the beginning of the crisis, it was more of a kind of an emergency and people were acting out of kind of just a crisis mode, basically. But I think as the crisis developed, and if we look now, I think that it's more about actually kind of start reevaluating how we're going to work during the next couple of months, but also looking into the future. So I would say that we've gone from being in a super urgent crisis emergency situation to actually starting to see people kind of lifting the eye a little bit and looking into the future. Yeah, I think the most kind of obvious one is that adoption was much quicker to develop in Brazil than what we see in the Nordics. I think basically two things. One was that generally speaking, and now I'm painting with very kind of broad brush strokes here, that people tend to be a bit more result orientated. So they ended up in a crisis where all of a sudden they couldn't meet their patients as they did before, and then they didn't wait. They started looking for solutions kind of right away. Whilst I would say in the Nordic, it was still a little bit hesitating, still like we don't really know. So I think that kind of adoption was much quicker in Brazil than I would say that it's been in the Nordics. Even though, I mean, as everyone is saying now, like digital visits is going up and so on. But still, if you look at the people who did not use digital visits before, I would say that adoption rate was much quicker in Brazil. I think the most obvious thing is that the market has matured very rapidly, probably matured a couple of years in just a few months. So I would say that we see much more opportunity than we see challenges if we look ahead of us. But some of the things that were challenges before the COVID crisis is of course still challenges. And I think at the base of it, kind of the hardest thing about digitalization is that if you do it well, it will actually change how you work. So, and that is always hard, and it's not something specific for healthcare. It doesn't matter which business you're in or which your what profession you have. If you're going to change how you work and how you kind of act your everyday kind of job, it is hard. So, and I think that it's our task as providers in that and service providers in that equation to make it easy. So I think that the biggest challenge, if we look kind of into the future, is that we need to make it easier and easier for healthcare professionals to actually adopt new technology. Because as we see now with the crisis, if anything, this has just put a megaphone on the challenges we had before. We had a challenge in all of the West world where we see that the costs are going up. We see that there needs to be performed more and more healthcare without actually increasing the spend. And because of the COVID-19 crisis, this has actually just been increased even more, because now we have started to build a heap of healthcare that has been postponed for months, that we now, on top of all the other challenges, we need to start reducing. I think, and this is actually one of the reasons why I was so attracted to Latin America to begin with, is that on one side, I told you that we saw a much quicker adoption rate. People were much more result orientated, and when they had a need, they kind of just jumped for it. The other side of that is attention span. So, I mean, it is, as I said, it is hard to change how you work. And for us as a company to be so easy to understand, so easy to adopt, that even though you're busy and you don't really want to spend time learning something new, you can still adopt a tool that will have a profound impact on your everyday business. I think that is the challenge. And it's we are really kind of just keen on taking that on, because from our perspective, we're not going to see ourselves as successful until we have hundreds of thousands of healthcare providers using our tool. It's so easy from a Nordic perspective to look at other countries and think that we're amazing and we're going to go out and teach people how to do things. But we have learned so much from working with the Brazilian customers we have today, and also customers in other countries, knowledge that we are bringing back to our Swedish and our Nordic customers. So I think it's so important that we and it's not that we shouldn't be proud of the things that we're good at, but to just keep an open mind and understand that things are done in different ways in different places, and there's so much we can learn from each other.
So we're a mental health platform for individuals and for businesses. And what we basically want to do is bring tools that help us improve our life and mental well-being, and make them available to everyone and the masses. Because traditionally, the way you have addressed mental health has been from only and primarily a healthcare perspective, that you put in efforts and resources once things have gone too far, once you end up with depression or with a burned out symptom, for instance. So we see a great need in changing that by enabling prevention-based tools. So that's why we use technology in an app, because it's so scalable. So we have tested our app on almost 2 million people across the globe, which we think is amazing. And we are residing in a small Swedish city, but can help people across the world. So that's something that really excites us. It's really interesting that you say that, how our mental state more or less affects everything. And we like to see it like it all starts with the mind. We think, therefore we are. And in these times, everything we're going through is passing through our mind. And depending on how that is dialed or tuned, that will affect the outcome. So what we've seen now during this pandemic, in terms of, if we'll look at stress, for instance, so the thing is that our brain needs to know where it's going. It needs to have a direction that brings comfort. When we don't know where we're heading or why, or there are uncertainty, we more easily go into stress. And this pandemic is, a textbook example of this. Some things become more simpler as well, but existentially much more difficult. And in general, what we do see is that the interest, so we have been trying to advocate the importance of mental health and well-being for the past 10 years. And now the acceptance and interest in this has skyrocketed. Because now, before the pandemic, it was the number one cause to sick leave was mental health conditions. And, we unfortunately, it had to come to this pandemic for people to really realize that this is not something we can continue to neglect. See it also with businesses. I think what we've seen challenges is that many purchase buying decision, everything has been put on hold due to the uncertainties, but the awareness and the interest that we really need to have tools to support our staff, to support the employees, and we don't really know how to do this. And what they do know is they, it's not technically feasible to provide a psychologist or a coach to everyone in an organization, but a digital scalable system, well, that's actually feasible. Now, in the wake of this, once things are stabilizing, what we do see is that mental health is one of the, or mental health conditions such as depression seems to be one of the big consequences and side effects of COVID-19. So I think there will be even more efforts in the area to help combat that in different scalable ways. And that's where I think that digital health can play a major role. I've primarily been talking to different white collar functions. Okay. And we see that these stress levels are increasing, and the problem it's kind of a catch-22 right now, because what happens with looking at the automotive industry, which has been heavily affected by COVID-19, obviously. So what happens is that they're making cuts, and the business is not going as it should. So they're cutting back on costs, they're cutting back on staff. That creates a lot of extra stress and uncertainty. Specifically, 6 or 12 months ago, you were in a business where everything was peaking like this, and now it's the complete opposite, and no one could have expected this. So what we see is the challenge is that they cut back on costs. So of course they're not in that situation looking at, okay, this is our well-being initiative, or now we are creating supporting resources for the staff to help cope with this. So that's where I see a challenge still in many different industries, is that what they need to do now, understandably, they need to, in many cases, reduce costs, but they also need to invest in creating a mentally resilient staff going forward, because that will be the key to managing the next time this comes. Yeah, exactly. And I think also there's the shift towards prevention that we've seen has been, in discussions with insurance companies, for instance, they've been talking about the importance of this for many, many years. But now I think they're going even more into acting mode due to the pandemic. We actually need to start doing things about this, and to start look at businesses. What we would be looking at, if you could look at different kind of organizations and look at, so you have their financial balance sheet, you have the sustainability reviews, but what about their kind of health reviews and mental health reviews? Yeah. And now there's data showing you, so if you have this amount of stress in an organization, this will cost you this much money per year.
And Joint Academy is a digital clinic for patients with chronic joint pain, and we connect them with physical therapists to deliver treatment online. So instead of you going and seeing your physical therapist at a clinical level face-to-face, we do everything virtually, and then we substantiate that with a lot of underlying clinical evidence. What's happened is that all elective surgeries has basically been canceled, at least at the beginning of the pandemic. I think they're slightly starting to opening up. Yes. Again. And when it comes to osteoarthritis and chronic joint pain, which we treat, elective surgeries is quite common. So that means, as you mentioned, there's a big pent-up demand, a lot of patients on the wait list. There's a big care backlog. And how we view that is that we could help these patients while they're on the wait list. So instead of going to their elective surgery, they could actually join Joint Academy, download our app, and start their treatment online instead. And that way we could really mitigate that care backlog and really help to offload and relocate those resources to us instead. So we view that as a very good mitigation from our point of view to definitely offloading the healthcare system here in Sweden. But it's the same thing is also happening in the US. I think the elective surgeries are still being canceled at a high rate, and especially higher risk patients in the US because of higher BMIs, more comorbidities and things like that. So for them to have an option to actually have a virtual treatment instead is very, very positive impact on the pandemic. So we've seen record levels of growth. So we're seeing several thousand patients a week, even a day. So we're definitely seeing that demand equation going up quite rapidly. And it's one of the other factors that also plays into this is that traditional physical therapy has also suffered somewhat because it's also, people with chronic diseases. So not only the elective surgeries, but also traditional physical therapy, which we could also substitute for. So we've seen very, very high levels of engagement and growth, but we're also seeing that a lot of patients are opening up and being more open-minded around trying digital tools. So I think for the overall adoption and the ecosystem as you position it, I think it's very positive. Because we do know that these digital tools work. They have been proven in several, clinical studies, such as we've also published, I think 10 now. So I think, yes, we're seeing a lot of adoption picking up quite quickly right now. Intuitively, people would think it's a huge differentiation between the health systems, but I would say there is actually a lot of overlap. CMS covers almost 40 million lives, so that could be seen as it's not a single payer, but it's a very, very big payer in the US where you could access a lot of covered lives. Like in Sweden, you have a public health system, and under that you have 21 entities. So it's quite similar that there actually exist public payers. The big thing with the US is that there's a lot of private payers as well, mainly that the employers pay for healthcare. Around 40% of the market is paid by your employers. I think that's the big differentiation. But aside from that, I do think there is a lot of overlap. And I think Sweden and US are good examples where you see high adoption rates because, for example, Teladoc, Livongo were companies that were quite early globally, and they happen to be in the US, so they paved the way a lot for telemedicine and reimbursement. And then in Sweden, you have digital providers like us, like Doctor, that is also seeing millions of patients in aggregation. So I think Sweden and the US has a lot of overlap. And I think it's actually two very prolific countries when it comes to moving the needle in digital healthcare. So I think the really good thing now, as we're seeing adoption picking up, is that we're getting more and more data in, and that could be used for clinical studies. And I think those clinical studies, then, if the outcomes are actually positive, that becomes the catalysator to actually, further expand the penetration and adoption of telemedicine. So I think that's very positive. And we, recently published a clinical study that was with a health economical focus that showed that we actually could deliver our treatment at a 75% less cost than seeing a physical therapist face to face. So I think just publishing more and more of those clinical studies and now getting more and more data will help the industry, and that will then make the regulatory aspects, the public entities being more open to reimburse and maybe ease some of the regulations to make this simpler and more accessible. And then that would then tie into the care backlog, the pent up demands. We could
treat even more patients.
So we could really mitigate, these long queues.
Exactly.
Patients don't have to be sitting in long queues and waiting for their care, that they actually know that there's a lot of different solutions and options out there.
And I would like to start talking about a BCG analysis made on media comparing 2019 to 2020. And we can see that telehealth has been ranked 4th in the ranking, whereas in 2019 it had not even appeared in that. So telehealth definitely is a hot topic right now, and Valentin is going to help us navigate through the trends in this situation during these interesting times. Welcome, Valentin, and thank you so much.
Thanks for having me.
So how do you see this, Valentin? How is the market responding to it or reacting to this situation?
Well, you mentioned the BCG report, and I think that this shows an increased awareness on the mainstream side of health. We've seen for many years the discussions around telehealth happening in circles of professionals or people that have some sort of activity in healthcare. But now we realize that we are all part of health, and this is why, out of necessity, we are starting to discuss about this. That said, the mere fact that we're discussing about this is encouraging, is great for awareness. At the same time, I'm not putting too much weight on it. Because in our circles of people that have been around this sector for a long time, we have heard discussions about telemedicine for the past 15 years. The issue has not been the lack of awareness or the lack of discussions. The issue has been the lack of action. And one of the fortunate, if you can put it like this, one of the fortunate outputs of this extremely unfortunate situation that we're facing is the fact that the attention has shifted more from discussion into action, and that has been very positive. And just to give you an example, in a country we've seen this all over the world. It has been telemedicine has been used out of pure necessity. But just to give you an example of what that means in terms of the implementation, in Denmark we had the first telemedicine platform was implemented approximately 6 years ago, 5 or 6 years ago. It took approximately 4 to 5 years of adoption and implementation and discussion and getting the right buy-in, etc. Then after that period, for 5 or 6 years, it hasn't spread to any other regions in Denmark until now. As the pandemic started, there was a very concerted effort, and it was quite amazing to see that resulted in the deployment of a national telemedicine, not a regional telemedicine platform, but a national telemedicine platform within 6 weeks. I think that opened people's eyes on, first, the utility of it, and second, on what we are capable of doing if we have action in mind. The step towards video consultations, which have taken off tremendously, is not the final battle. Is just the first step towards what we would like to see, which means bringing remote monitoring closer to the patients and taking the care outside of the institutions as much as it's possible, towards prevention, continuous monitoring, etc. It's great to celebrate the video consultations, and this is the field that has taken off the most. There is still a very big struggle when it comes to remote monitoring and anything that has to do with data access and the steps towards personalized medicine. So to answer your question, telehealth is the biggest standout here. Just one note here.
Yes.
A professor of oncology here, her name is Helle Papot, made a very strong point around the fact that the value of health tech is not only to shift what we are already doing physically, but in a digital way. But the biggest value of health tech is to shift the ways that we are doing things right now.
Totally agree.
to improve them or to turn them upside down completely. And video consultations do exactly that. They take a physical meeting and they put it digitally, and there's value in that. But this is just the beginning.
Absolutely.
I would like to make one more note, and that is that while in terms of adoption and usage, video consultations have taken off tremendously. In terms of investments, there are quite a few other areas that have gotten attention. Despite the economic downturn that we've seen around the world, health tech or digital health, or however you want to define it, has seen a tremendous increase in investments. It has been the first 2 quarters of this year have been by far the most financially productive quarters when it comes to investments in health tech companies. That means that there is a lot of trust, and there is a big belief that many other solutions are going to be adopted. At the moment, though, there is a disconnect between the belief and what is actually being adopted, though.
Absolutely, I totally agree with you. And talking about investments, where do you see the major sources coming from? From investors that have already been investing in telehealth in health tech? Do you see investors that have been focused in other areas that are coming into health tech? How do you see that area developing?
Well, we should start by saying that there aren't many investors that have have been focused on health tech for a long time, because this is a new field. Right now, I see this shift changing. You would see let's say, people that would be very close to healthcare being at the forefront of investments. Then investors that would have a background in biotech and pharma and so on, and then these agnostic investors. At the moment, I feel that the investors that have been investing in many other sectors have stepped up, because they see many opportunities. They understand better what health tech is about, and they can see a lot more opportunities in health tech. So there was a shift. There has been a shift when it comes to that, and this also has to do with the fact that, despite the economic downturn, the typical investment let's say sectors and ways are not that profitable anymore. Money is coming out of the markets, of the stock markets, and they are looking for places where they can get better returns.
Yeah, I totally agree with you. And for instance, if we talk, let's say, about the U.S. case, where if we get to the point in which the markets realize how economically beneficial it is to incorporate health tech solutions to, let's say, a healthcare provider, a private healthcare provider, and you see the positive cost saving, let's say, or efficiency outcomes, and you see the multiples of it. I would say the incentives would be very, very much gravitated towards having many more investors come into this area. No?
Yeah, I'm definitely on the same page from a patient perspective,
Absolutely.
but also from a former provider perspective and so on. And even talking to the companies that we have here, and some of them have closed pretty good rounds. Who is going to invest in you matters. It matters for your direction, and we don't want this to become a quick buck making business where there is a very high turnover of short-term gains and then selling things out very fast.
What about mid-income economies, i.e., I don't know, Latin America, Southeast Asia? Have you seen any different behavior on the adoption of health tech during this crisis? For instance, I have seen in Latin America that, first of all, the concept of health tech has been talked about, whereas before never been talked about. And since primary wards and hospitals are even turning down patients because of this whole crisis, they have started to improvise through the existing technology to be able to deliver health through even WhatsApp or Facebook. So I do see a big potential in these ecosystems, in these scenarios. Do you have a take on that?
Well, what's important to say is that the majority of the world's population is not in highly developed or economically highly developed countries, and that is something that we always need to keep in mind, and we speak to the startups as well. Is this transferable, or is this only going to work in a highly equipped, highly functional, top-of-the-line Danish hospital? The value that we can bring through health tech is all over the world. Now, there are a couple of I think that's this discussion is also the countries are not homogeneous. Yeah. What I love about countries that are whose systems are not as structured is that things can move much faster from the grassroots. Several countries, and telemedicine is one of the good examples. Telemedicine has been used more in low and middle income countries before COVID than in high income countries.
Oh, yeah.
I think that the possibilities in these countries are endless, regardless of how big you build a hospital or how many hospitals you build. There will never be enough to cover all the places, and also in terms of resource allocation.
Absolutely.
If you live in rural Alabama, or if you live in the countryside in Peru, and you need an ophthalmologist, you may even have a hospital next to you. But do you have an ophthalmologist? The competency that you need at that time. And this is the beauty of health tech, that it removes this barrier that cannot be overcome.
I would like to start asking you a little about what you've done and implemented in your organizations during COVID-19.
We have worked a lot on scaling up what we had before. Like, we had a lot of pilots ongoing, so we have actually really scaled up the monitoring of chronically ill patients at home, patients with diabetes and heart failure. We have also implemented in a hurry our digital platform in our primary care centers in Sweden. So at least 40 of our 100 care centers were not digital when the COVID crisis struck us, but now we have implemented 40 new care centers. So now we can have chat conversations and video conversations and do a lot of things remote with our patients. So that's the two things we have scaled up. Then we have done some specific COVID activities as well, like a fully automated lab process with using RPA technology for testing PCR technology, COVID-19 lab testing. So that's something we created during the crisis. The first part was scaling up already existing things.
We have also continued on some of the pilots we already had, for example, with distance monitoring through the LifePod concept, and we have another concept called Hitachi that we have also used before, and we have been able to scale those things up quite a lot, and we made we could buy these systems for a shorter period of time during this COVID crisis, which has enabled us to implement them in more services. So Skåne University Hospital is a hospital with 14,000 people working here, and we serve an area of 1.6 million people in our 5 hospitals. And we had already a program when we tried distance monitoring for heart failure and chronic obstructive pulmonary disease, and now we have expanded that to 8 different areas where we try it, and it has been very positive. We also have some other got some initiatives from companies in the surroundings here during the crisis, allowing us to monitor the patients in the hospital rooms with cameras and other ways, so the nursing staff wouldn't have to enter the room, and they could monitor the patients outside. So there has been a great collaboration with the local industry here, and all of this is of course time limited for just this crisis, but it has given us a good start, and everybody has been able to try these things.
Yeah. What would you say are the nicest results you've seen from these implementations?
Yeah, with this distance monitoring, we see that we have a much better contact with the patients. We have a daily contact with the patient that way. At least for the patient, they feel it that way, and also they get a better understanding of their own illness. So they understand the different symptoms and signs, and they take care of it better. And we have actually found a number of health issues that we wouldn't have been able to detect from regular visits. Things that one man who had a sick sinus syndrome that we could find that way, and another lady who we thought didn't take her medications as she should, and it turned out that she had a pheochromocytoma, but that we could actually follow up on things. We saw that this is not a matter of lacking of compliance to the medication. There must be something else, and then we could pursue it. So, and the patients, they feel safe. They feel monitored, and they have a much better contact with us. And when we need contact with them, when we see something is wrong in the distance monitoring, usually we can handle it all over the phone. So in 9 out of 10 cases, we can do that. So It has been very good. It's very positive, and the patients and the doctors all are very positive to this.
Yeah, I can just agree with Per-Ola. It has been a positive experience for patients, but also for doctors and nurses. Some of them were a bit skeptical before the crisis, but now everybody could actually understand the value of it from both the patient and a staff perspective. I would say that accessibility has increased in our primary care centers, that people could actually access healthcare much easier than before. And striking is actually the good parts of collaboration, both internally in different organizational structures, but also between public and private partnerships, and all of those things has been really amazing during this time, I think. I hope that we can stay.
Yeah.
Forward.
What are your thoughts? What are your main issues or considerations making that happen?
To have structures that allows us to experiment further, and some of the reimbursement models have also they have changed during the crisis, but only for a limited of time. So I think it's important to keep the new ways of getting reimbursement for digital contacts and things like that. So that's my takes.
So how would you say that is solved? The reimbursement models that change for a while, who decides if they're there to stay?
Well, in France, it's the French government. It's a national system for reimbursement. So we really hope that they will keep this, and also in Sweden, some exceptions as well, so that you actually could have like monitoring chronically ill patients, so that you don't have to go back to the traditional way of delivering care.
First of all, we have to, since we are a public enterprise, we have to follow the rules in the EU for the procurement of these systems that we have tried. That will we hope that process will be speedy enough for us to pick up, so we don't get a gap from where we are. That's the number one. And there are a number of things. Many of these things are cloud-based, the services, and which is not very well seen here in Sweden because of some developments we have had in other sectors with servers being abroad with sensitive data about Sweden. So those things have to be addressed. Other things are, as I understand from Tuva's answer, it has to do with reimbursement. For example, for many patients, video visits, they have to pay almost as much as they do for a regular visit, whereas if they have a telephone consultation, it's for free. So for the patient, they see very little additional value in seeing the doctor in a picture, and they don't see it's worth that much more. So they prefer the telephone contacts. Whereas, and also we have had some, we need a little bit better technology for it. Other things is just with the distance monitoring, how is that to be paid from the government, because it's not a regular visit, and we need a new model for distance monitoring and the reimbursement for that.
So what can you do from the university hospital or Region Skåne, the local government, the regional government, when it comes to these things?
I think we can solve many of those things. We just have to address them, and many of them we weren't quite aware of all the aspects until we tried it. So that's the good thing. If we should have waited and trying to anticipate every kind of problem before purchasing these solutions, it would take years, and we wouldn't be good anyway. Now we crashed into it, we had to try it, and immediately we saw all the things that have to be fixed, and then we can address them much faster and do it. Because now our resolve is we cannot handle this situation ahead of us without these solutions. It's absolutely necessary. So there is no other way for us. We have to keep on to this and develop it.
We really need to continue this journey. That there is the point of no return has been reached. So it's just a matter of adjusting to the last couple of months. Normally this would probably take around 3 years, and now we have in 3 months we have done amazing things around a lot of operations. So it's more about keeping the speed and the hope up, and actually to be able to transform some of these more long-term perspectives of how do we want the system to work from an innovation perspective and from a reimbursement perspective, from a technology standpoint, regulations, rules.
That you see is a hurdle when adopting it even more widely within your organizations?
Yeah, absolutely. They are still it's still a siloed system where you have this service as a standalone service in many ways. We're trying to work a lot on data and how to be interoperabilities. How can we use data from many data pools? So a lot of these things gets back to infrastructure from our perspective, but also from rules and regulation. Where is the data? How can we use the data so that we can even be better in taking care of our patients?
We have to think new about many things and see what of this can we apply and where, and we will still need the regular visits, but maybe we should turn it around to see to make the default being the digital visit and the exception being the physical visit, because we have to have that mindset. We don't really have that quite yet.
I think it's a lot about onboarding and teaching people on how this can be used. And now during the COVID crisis, a lot of people, also elderly people, have tried something new. And I can just have a look at my parents and people around me that they can adopt digital solutions very well. I think they have a high usage of digital services.
In this in a positive way. The only thing they have been skeptical against is this bank ID. It's a digital identification that we use for bank services and different things in Sweden. I think one essence of healthcare is the relation that you build between the caregiver and the patient. And actually many patients feel with a system like distance monitoring, they feel that it extends the relation. It's a good thing that they already have some kind of relation to the doctor that they are communicating with, because in their mind they feel this is the doctor who is in charge of this, and it's not an anonymous thing. So we should care for these relations, and actually these digital systems makes it easier to keep them, because you always have the feeling you are in contact with the same doctor, and they feel actually they get the feeling that they are actually communicating with their doctor when they have this distance monitoring, and they feel that it's their caregiver who's looking at them. That's the human aspect of it, and it doesn't need to be lost. It's actually enhanced with this technique, other than they come and see different doctors all the time, and they come to emergency wards because they are not well taken care of. Here they have a relationship, and it's a way of keeping it.
So, you've all seen the first wave of health tech solutions, providing online visits to doctors and other professionals. Some of us have seen the second wave already. That is health tech treating, decision-making tools, remote monitoring, and things like that.
Yes, Marianne. In fact, like Tova said, the point of no return has been reached.
Yeah.
And for example, Per-Ola said, we cannot handle this situation ahead of us without these solutions in place.
No. We're at the forefront of this. Together, we can change world care. If you have any questions whatsoever, get in touch with us. Thank you.
Thank you.